Good morning, Dr. Dempsey.
Good morning, sir.
You can hear me, obviously, and you can see me, can you?
Yes, I can.
Good. Now, let me set the scene for you. You are talking to a very small group of people here in Aldwych House in central London. But the main audience who want to hear what you have to say is listening remotely. There may be 100 or so. I suspect that we will be joined by quite a number from Northern Ireland, for obvious reasons. And they are the people who are particularly interested in what you have to tell us. You're at the Belfast City Hospital, are you?
Right.
And present with you in the room is no one?
No one at the moment.
But in the building there are your legal representatives and a technology expert, just in case things go wonky.
That's right.
In a moment, once Mary has invited you to take the oath, the affirmation, in your case, Ms. Richards will ask you some questions. Mary.
Please state your full name
Stanley and Dempsey.
and repeat after me. I do solemnly, sincerely
I do solemnly, sincerely,
and truly declare and affirm
and do truly declare and affirm
that the evidence I shall give
the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Dr. Dempsey, can you see and hear me?
Yes, I can.
I'm just going to start with an overview of your career. You undertook house officer and senior house officer roles in Belfast City Hospital between 1970 and 1973. Is that right?
Yes.
And then your statement tells us that between 1973 and 1978, you undertook senior house officer, then registrar, then senior registrar roles in haematology at Belfast City Hospital. What broadly did that work entail? What kinds of haematological conditions were you involved with?
Well, primarily with malignant conditions and general haematology.
In 1978 through to 1979, you were a senior registrar in haematology at the Royal Victoria Hospital and the Royal Belfast Hospital for Sick Children. Was that your first work as a senior registrar with the care of patients with bleeding disorders?
That's right.
And were you working there under Dr. Main at the Royal Victoria Hospital and Dr. Bridges at the Royal Belfast Hospital?
Yes, that's right.
You then, I think for the first half of 1980, had a post in paediatric oncology at the Royal Manchester Children's Hospital. Is that correct?
That's correct.
And then you returned to the Royal Belfast Hospital for Sick Children in August 1980 as a consultant paediatric haematologist, remaining in that role until your retirement in 2008. Is that correct?
That's correct.
I'm going to ask you a little more now about the services and facilities in haematology at the Royal Belfast Hospital for Sick Children, with particular reference to the care of children with bleeding disorders. In terms of the staffing, is it right to understand that for a number of years you were the sole consultant haematologist, and it was rather later on that a paediatric consultant oncologist was appointed?
That's right. The pediatric oncologist, consultant pediatric oncologist, joined me in 2000, the year 2000.
And so if we think about the 1980s, there was you as a single-handed consultant, and then you had the assistance, I think, of a registrar in haematology who presumably changed as they went through their rotations.
Yes, a rotating registrar. Yes. Sometimes an SHO.
And then your statement explains there was also a part-time clinical medical officer from 1987. What was the role of the clinical medical officer?
Well, the clinical medical officer was primarily to assist me in looking after the patients I cared for. Children with general hematological conditions, children with malignancies, and children with bleeding disorders.
And so is it right to understand that there was no, in the 80s at least, or until I think 1987, there was no specialist nursing input in relation to haemophilia care?
That's correct. There was no specialist nursing.
And was there any sorry?
Children were seen on pediatric medical wards. They had, some came to one ward, some came to another. They were spread across 2 wards in the Children's Hospital, Musgrave Ward and Allen Ward.
And to what extent was there social work or physiotherapy availability for children with bleeding disorders in the 1980s?
Well, there was a physiotherapy department, and we could access help there as we needed to. We had no designated physiotherapist. What else did you ask me there?
Social work.
Sorry. Social work, yes. We had a Malcolm Sargent social worker who was funded from a charitable source. And she was able to provide some help with patients who had bleeding disorders, but she was there primarily to look after children with malignancies.
And your statement says that essentially there were, your clinical responsibilities covered children with leukemia and solid tumours across Northern Ireland, children with bleeding disorders across Northern Ireland, and then general haematological clinical issues. Is that right?
Yes, that's right.
And then it was in 1987 that rather than patients being seen on the general medical wards, a specialist unit opened.
That's right. 8 beds and a complement of nursing staff.
Sorry, carry on.
So the nursing staff would get to know the patients with bleeding disorders, and they had an ability to relate to patients with bleeding disorders and take an interest in them in the way that hadn't happened up until then.
Now, your statement suggests that you looked after children with bleeding disorders until they were 14, at which point they would be transferred to the adult haemophilia centre at the Royal Victoria Hospital. Why was the age of 14 chosen?
Well, the age of 14 was already established when I was appointed. The Children's Hospital management were quite keen that children shouldn't stay as patients in the Children's Hospital after the age of 14. And the management in the Royal Victoria Hospital was quite keen that the adult hospital shouldn't look after patients younger than age 14. So that was a cutoff that was established before I joined the hospital as a consultant.
I'm just going to ask you to look at one document with me on this issue. Sally, could we have WITN 4027002, please? This is a 2000 report of an audit visit. If we go to page 3, the top of the page, it says Pediatric Services, Royal Belfast Hospital for Sick Children. All children with haemostatic disorders are seen at the Children's Hospital. They get transferred to the adult service usually after their 16th birthday. Is that incorrect, or did the practice change in terms of the age of transfer?
That's incorrect. It was 14 when that audit took place. It may have changed subsequently after my retirement. I think there was a move to extend the age range of patients looked after in the Children's Hospital, but I don't know a great deal about that. I think that might have happened after I left, but certainly in 2000, 14 was roughly the cut-off period, the cut-off age for transfer.
And sorry, carry on.
Obviously, some children might have been a little over their 14th birthday by the time they were referred. They wouldn't be much under their 14th birthday by the time they were referred.
And how was the transfer managed or coordinated with the adult centre?
Well, not as well coordinated as it is apparently now. Generally speaking, I spoke to the parents, advised them about the upcoming transfer sometime in advance of the date, talked to them again before the children were transferred, probably spoke to Dr. Main in the adult unit and told her that child X was going to be referred across. Then I wrote a fairly extensive referral letter outlining their history in the Children's Hospital over the years they'd been attending, and gave that to her. Usually the chart went over with the letter for her to look at before she actually saw them over there. That was the extent of the transfer process that we engaged in.
So would it be right to understand from that there was not any joint decision-making in terms of a continuity of treatment or what the treatment regime might then be at the adult hospital?
Well, I didn't know what was going to be in the adult hospital, but I did my best to let Dr. Main know what we'd done in the Children's Hospital. I think it was pretty important that she did know exactly how treatment had progressed, what the particular problems were with that individual child, and all the other aspects of their hematology. I think I did do my best to outline that pretty carefully in the letter of referral so that she wouldn't be in any doubt about any of the issues. Obviously, if she had any problems, she'd have phoned me fairly quickly to clarify matters.
Now, your statement tells us that in the 1980s, there was a small cohort of bleeding disorder patients under the care of the Royal Belfast Hospital. You've estimated it was about 12. And you've said they were all children who were moderately or mildly affected, with no severely affected patients in the 1980s. Is that correct?
That's correct, yes.
Do you know how that came about? Does that mean there were no severely affected haemophiliac children receiving care in the 1980s? Or had some of the severely affected children already been transferred to the adult centre at a younger age?
No, there weren't any children who were severely affected in Northern Ireland being treated. They weren't being treated anywhere else. They just weren't there during the 1980s.
And that cohort of...
When you say 12 children, well, 12 to 14, roughly 12 to 14 children in the unit at that time.
And can you recall whether you had any patients at that time in the 1980s with haemophilia B?
No, we didn't.
So the patients were they all haemophilia A, or were there also some with von Willebrand's?
Mostly haemophilia A. There were some von Willebrand's.
And then I think your statement tells us that from 1990, you began to see both more children and to start seeing severely affected children. Is that right?
That's right, yes.
Now, in the period up to 1987, when the specialist clinic or specialist unit opened, were there regular haematology clinics or regular clinics for patients with bleeding disorders, or was it just a question of patients turned up as and when they had a bleed?
There were regular clinics held on the ward. They were attached to. The children were attached to. When they needed to come in between appointments, they turned up on that particular ward. They would phone the ward before they came, and then they would come up to be seen on that particular ward, have their problem looked at and attended to on that particular ward.
So in terms of the regular clinics, how often, leaving aside ad hoc attendances when there was a bleed, how often would you usually expect to see your paediatric patients in that period, 1980 to 1987?
Well, I think every 4 months or every 6 months, 4 to 6 months.
What were the arrangements out of hours? So if somebody had a bleed out of normal hours, what would happen?
Well, they would ring the ward they were associated with. And then the nurse would either speak to the SHO who was on call, the pediatric SHO who was on call, who would ring me, or they might ring me directly. And that was the usual arrangement, apart from when I was on holiday. When I was on holiday, the nursing staff would ring the pediatric SHO, who would ring the hematology senior registrar on call, who would deal with the problem. And if there was a serious problem, Dr. Main would be asked for her opinion. So that was how it operated.
Now, your statement tells us that home treatment was not introduced until 1990. Why was that?
Well, that was because the children were very mildly, moderately affected. Their attendances were fairly infrequent. And I didn't arrange for home treatment then because I thought they weren't severely enough affected. I thought that while we might be able to teach the parents the technique of venipuncture, if there were long gaps between actually treating the child, their technique might decay and they might have problems. If several weeks elapsed, or maybe a month or two between treatments, and this was quite standard with this group of children, I was worried that the parent who was able to do it 2 months ago might find that their ability had declined in the interim. So I thought probably best to see them on a periodic basis, or see them when they needed to be seen, rather than devolve that responsibility to the parents.
And is it correct to understand that the same is the case in relation to prophylactic treatment? That only became a feature of treatment at the Royal Belfast Hospital in the 1990s?
Well, that only happened in the 1990s, when we had a group of severely affected children who needed to have prophylactic treatment for their management.
Now, the Royal Belfast Hospital for Sick Children was, as I understand it, an entirely separate hospital from the Royal Victoria Hospital. Were they on the same physical site, however?
They were on the same physical site. They were separate hospitals. There was a unified management system.
And what does that mean, a unified management system in practice?
Well, there was a general manager who looked after the whole of the royal site. I think that's the easiest way to do it. There were obviously managers at a lower level whose responsibilities either referred to the Royal Victoria Hospital or to the Children's Hospital. But there was an overarching manager for the Royal Group, as it was called.
And you say in your statement, you were solely responsible for clinical decisions and decisions regarding product selection for your patients. And would it be right to understand Dr. Main was responsible for the clinical decisions and decisions regarding product usage for her patients?
Yes, that's right.
What extent of interaction did you have with Dr. Main in the 1980s?
Well, Dr. Main was a respected senior colleague. She'd been in post for some years before me. We would see each other periodically. We would generally see each other at laboratory management meetings, maybe once a week or every once a month or once every 6 weeks. We would see each other at meetings about the rotation of junior staff and the education of junior staff. We would meet in that sort of context. If there were matters relating to haemophilia, then we could go along to Dr. Main's office and discuss them. She was always available for me to ask about any clinical problem that I had difficulty with among my haemophilia patients. And I could ask her, and she was always very willing and obliging with her help.
The Blood Bank and Coagulation Laboratory were based, as I understand your evidence, at the Royal Victoria Hospital and fell under the responsibility of Dr. Main.
That's right.
And to what extent did you have ongoing dealings or relationship in the 1980s with Professor Bridges?
Well, Professor Bridges was in charge of the academic department of haematology. He also had responsibilities for patients with malignant disease, and those patients we looked after in Ward 22, Royal Victoria Hospital, which is also the ward where the adult haemophilia patients were looked after. His remit was entirely around general haematology and malignant haematology. He wasn't, as far as I know, involved in the care of adults with haemophilia, although I think he probably did cover Dr. Main when she wasn't there.
To what extent did you have direct dealings or interactions with Dr. Maurice McClelland, the Regional Transfusion Director of the Northern Ireland Blood Transfusion Service? Well,
I knew him, and I related really to him when I had a need of his service, and very helpful the transfusion service were. I didn't meet him on a regular basis, no, but he was very helpful around providing blood products for my patients over the years, and they bent over backwards to help and look after them. And I'm referring really now to patients with malignant disease who often required a lot of platelet transfusions and the like.
To what extent did you have any regular or ongoing interactions with other paediatric haematologists looking after children with haemophilia elsewhere in the United Kingdom?
Well, not a great deal, but I would meet them at meetings related to general haematology and hematological malignancy. People who went to those meetings often had a remit also looking after children with haemophilia.
And were there any particular paediatric haematologists looking after children with haemophilia with whom you had more contact than others?
Well, I couldn't say particularly. If I had needed to consult with a paediatric haematologist about haemophilia, I probably have spoken to colleagues in Glasgow or in Yorkhill, but that didn't arise too often. We had quite good links with the Pediatric Hematology Oncology Unit in Bristol, but I don't know that they were involved in haemophilia care. I don't think they were.
Now, in terms of the service at the Royal Belfast Hospital for Sick Children, was it a recognised haemophilia centre with UKHCDO? Did it have a centre number in the 1980s?
Well, not that I'm aware of. I think we were established in tandem with the Royal. The Royal was a comprehensive care centre. The adult centre was a comprehensive care centre. And we would look to the facilities in the Royal to support our care of the haemophilia patients in the Children's Hospital. So we were linked to the adult haemophilia unit. I don't think we were ever recognised as being separate in any way, although in a from a de facto point of view, we were separate. From a patient management point of view, we were separate. But as I say, we look to the adult unit for support around coagulation, especially the coagulation laboratory was based in the Royal.
Does it follow then that in terms of the information about how many products were being used and what type of products were being used in any given year, data relating to the Royal Belfast Children's Hospital would be included in the annual returns that were submitted by Dr. Main to UKHCDO? You didn't submit separate returns?
No, I didn't submit separate returns, that's right. She amalgamated the returns from the Children's Hospital and sent them to Oxford as a unified whole.
Now, in terms of attendance at annual meetings of UKHCDO, the minutes which the inquiry's seen suggest that you may have started attending regularly from around 1988. Does that accord with your recollection?
I would have thought that I attended earlier. From memory, I would have thought that I had gone to some of the meetings earlier. That's my recollection, yeah.
Whether or not you attended at the annual meetings in person in any particular year, did you receive the minutes of the UKHCDO?
Yes, I think I did, yeah.
And you said in your statement that Dr. Main would also keep you up to date with what was being considered at UKHCDO level.
Yes, if there were matters of general interest that would be discussed, and she would discuss them with me.
Now, the inquiry understands from evidence it's received and heard that in the early 1980s, a link was established with the Protein Fractionation Centre in Edinburgh so that plasma collected in Northern Ireland, previously possibly sent to BPL, but would be sent to Edinburgh for fractionation, and in return, in Northern Ireland, you'd receive the SMBTS factor concentrates. Did you have any involvement with the discussions that led to the establishment of that arrangement?
No, none at all. I was aware that it had happened in 1982, but I wasn't involved in any discussions around it.
And do you recall involvement in any discussions in Northern Ireland in the early 1980s about self-sufficiency and trying to achieve self-sufficiency?
Well, not particularly in Northern Ireland, but the philosophy of self-sufficiency I do recognise from an early date. It was very much on people's agenda. Yes. I mean, the idea that the state should collect from volunteer donors sufficient plasma to provide the blood products required by patients living in that state, I think that would summarise the philosophy. And it seemed to me a perfectly sensible one, rather than relying on other nation states for plasma products.
And do you have any knowledge as to why the arrangement with the Protein Fractionation Centre wasn't established earlier than it was?
I don't know why. I think we had a relationship with Elstree and the English Fractionation Centre prior to 1982. I don't know how that particularly arose. I think Elstree decided that they were going to distribute their products on a pro rata basis dependent on the collection of plasma from the various regions of the UK, including Northern Ireland. Northern Ireland had difficulty initially in shipping fresh frozen plasma to the fractionation centre in England. And eventually, I think the arrangement with Scotland was arrived at because Scotland had the capacity to deal with the plasma that Northern Ireland was prepared to send, or could eventually send once the actual arrangements were established for sending it.
Now, I'm going to ask you shortly about your own use of SNBTS concentrates, but before we look at your own approach to treatment, the information the inquiry has in relation to treatment at the Adult Hemophilia Centre at the Royal Victoria Hospital suggests that commercial concentrates continue to be used to a very substantial extent from 1982 onwards in the first half of the 1980s. Do you recall whether you were aware of that or ever had any discussions with Dr. Main about her use of commercial concentrates?
Well, I was aware when I was a senior registrar in the adult haemophilia unit in 1979. I was aware that that commercial concentrates were used fairly extensively. After that, I lost contact with the arrangements that pertained in Ward 22. So I didn't really have any clear impression about how extensive commercial products were being used in the adult centre after I left as a senior registrar and ultimately became a consultant. As to whether she spoke to me about it, no, she didn't. She didn't speak to me about it. My arrangement with the blood bank was that I used the products that came into the blood bank. Dr. Main negotiated for the products that came into the blood bank, be they blood products from SNBTS or elsewhere, be they commercial blood products. I selected from the products that were in the blood bank and used them to treat the patients under my care. But I wasn't responsible for bringing product into the blood bank in the Royal Victoria Hospital. That wasn't one of my responsibilities.
So
that was very much her responsibility.
So you had no involvement in the ordering arrangements in the 1980s?
Oh, I had no arrangement, no part to play in the ordering.
And was that because that's just how it was and that was the situation you inherited? Did it strike you as odd or concerning that as a consultant haematologist caring for children, you weren't having a role in those arrangements?
Well, no, it didn't bother me particularly. I didn't aim to have a role. After all, in the 1980s, the amount of product that I was using for the children under my care was pretty limited, pretty small. As we said, this was a cohort of mildly to moderately affected children who came irregularly for treatment. And their usage was not great. So the bulk of the material that was brought into the blood bank would have been used in the adult centre. And it would always have been appropriate that Dr. Main did the ordering around that.
going to ask you to look at a set of minutes. It's a meeting you were not present at. I just want to ask you whether a particular issue was something Dr. Main discussed with you. It's LOTH 000012_122. You'll see, Dr. Dempsey, that this is a meeting of Hemophilia Reference Centre directors, September 1981, and the list of Reference Centre directors are there set out, and we can see Dr. Main was at the meeting. If we go, please, to page 5. I just want to pick up a discussion at the bottom of the page and over the page, Dr. Dempsey. So under the heading, Distribution of Factor VIII and Other Blood Products, the minutes record this. Professor Bloom referred to a meeting in April which the DH had called and to which representatives of the plasma fractionation laboratories, Haemophilia Reference Centre directors and blood transfusion services were invited. The main problem for the Haemophilia Centre directors was a recommendation from the Department of Health that blood transfusion centres should purchase, hold, distribute and control the stock of all blood products, including Factor VIII supplies. The Department of Health claimed that the Haemophilia Centre directors would still have a say in which materials were purchased, and that this system would enable the Department of Health and the Blood Transfusion Service to have monthly returns on the amounts of materials which were purchased and used. The Reference Centre directors were most concerned about the effect of the DHSS's proposals on the day-to-day running of their clinical practice. It was felt that the scheme would result in a loss of flexibility, and then there's a worry about budgetary issues. And then if we just go to the last sentence of that paragraph, after much discussion, it was agreed that the Haemophilia Centre directors would resist strongly the transfer of Factor VIII stock control to the blood transfusion service. Dr. Dempsey, recognising as I do that's not a meeting that you were present at and you probably wouldn't have seen the minutes, was that issue the issue of whether Factor VIII stock control should be transferred to the blood transfusion service and the resistance of the Haemophilia Centre directors to it? Was that something that you were aware of or that Dr. May never discussed with you?
No, I wasn't aware of that, no. Dr. Main appears to have held the budget for the at least initially held the budget for the purchasing of commercial Factor VIII, as far as I was aware. She did the negotiating, and I presume she held the budget for those purchases, at least initially. I think I remember that eventually the invoices went to the Blood Transfusion Centre, and Dr. McClelland, the commercial product came to the blood bank in the Royal. I think that was ultimately the decision that was arrived at somewhere along the line. But back in 1981, I think she probably held the funds for the purchase of commercial product.
Going to ask you now to assist us with understanding the approach to treatment that you adopted from 1980 at the Royal Belfast Hospital for Sick Children. So your witness statement tells us that from August 1980, when you took up your post, to December 1982, you used some commercial concentrates, Armour and Hemophil, also NHS Factor VIII and cryoprecipitate. Is that right?
Well, when I took up my post, I think cryoprecipitate was used fairly exclusively in the unit. We had a difficulty with a patient in 1981. A child was admitted following an accident. There was no evidence of bleeding, moderately affected child, no evidence of bleeding. But I think, and I don't recollect the full details of the accident, I felt that it was important to admit the child and cover the accident with Factor VIII. So cryoprecipitate was given to get the factor level above 100%, keep it above a trough level of 50%, and see that it was given 8 hourly. The child had no evidence of bleeding in the late afternoon, evening, but despite the regime being closely followed, the following morning there was evidence of an intra-abdominal bleed, an intraperitoneal bleed, which was verified on ultrasound and which was a very worrying development. The surgeons weren't keen to intervene, naturally enough. So at that stage, I turned to the use of concentrate, and concentrate controlled the bleeding, and the child began to pick up. The bleeding was extensive enough for the child to require blood transfusion. A factor level was done, and the factor level was less than 10%, whereas it should have been above a trough level of 50%. And there was no evidence of an inhibitor. So that, to me, suggested that the cryoprecipitate had failed to do the job that was asked of it on that occasion. And it definitely shook my confidence in cryoprecipitate, because we were looking at a very serious clinical situation that might have deteriorated with fatal consequences if it hadn't been picked up on the ward round. And at that point, I introduced commercial treatment for this small group of moderately affected hemophilia A patients after discussion with the parents and after due consideration of safety concerns. And that's the situation that remained in position for this small group of patients. Cryoprecipitate remained as a treatment for mildly affected hemophilia A patients and von Willebrand patients. But as I've said, the commercial product was used for 2 years, from 1981 to 1983. And in June 1983, in consequence of the letter that came from the UK HCDO, those children were transferred to SNBTS concentrate at that point, and we stopped using commercial material.
So
that, of course, the AIDS, the developing AIDS problem.
So just to understand the chronology, is it right then that in 1980, joining the hospital as a consultant in August, you continued your predecessor's policy initially of using cryoprecipitate, including for the moderately affected children? It was the incident you've described in 1981 that led you to switch from cryoprecipitate to concentrates, commercial concentrates, for moderately affected children, and then you switched again in June 1983. We'll look at the letter in due course, but the letter from UK HCDO, you then stopped using commercial concentrates. And at that point, did you then use the SNBTS concentrates?
Yes, SNBTS concentrate, yeah, from that point on, yeah.
In terms of the type of commercial concentrates used during that intervening period, your statement suggests it was Armour and Hemophil. Was that simply a reflection of what was in stock at the blood bank, or was that a conscious decision on your part to choose those products rather than any other product?
No, that was what was in the blood bank at that time.
In terms of
Hemophil in 1982, I think, was being purchases were being reduced, and Armour factor 8 was being increased. I think that was the pattern that was established in 1982. But yes, Hemophil and Armour were the two products that I used in that small group of moderately affected hemophilia A patients.
In terms then of the choice between commercial concentrates and NHS concentrates in this period from 1981 to June 1983, why did you not choose to use SNBTS concentrate in preference to the commercial concentrate?
Well, I suppose SNBTS wasn't available in 1981, but they only established the link in 1982. But Elstree would have been available. In 1981, the AIDS scare, the AIDS crisis hadn't begun to emerge. The main safety question was around non-A, non-B hepatitis. Hepatitis had been associated with commercial concentrates in the mid-70s, but a lot of those cases had been hepatitis B. And the firms were keen to advise us that that problem had been tackled with adequate testing of their donor population. They were also keen to emphasize the fact that they'd tightened up on the type of donor they looked to for their plasma source. So given that reassurance, I was disposed to look favorably on commercial products at that point in time. I chose a commercial product because it was, the commercial product was easier to reconstitute, but that's not an essential feature. What was more important was that you could make the commercial concentrate up in a much smaller volume, and it was less viscous. And that meant that it was easier to administer into the veins of a pediatric patient. And I found that the volume of reconstitution was quite helpful, and that's what tipped me over into favouring commercial concentrate at that time. I wasn't persuaded at that time that the incidence of non-A, non-B hepatitis was greater in recipients of commercial product by comparison with those who received NHS concentrate.
I want to come back in a little while to the issues relating to the hepatitis risks and relative risks of hepatitis. But can I just ask this? You refer to a degree of reassurance. I'm not sure that's the word you used, but that's my summary, from pharmaceutical companies about their product from a hepatitis perspective. And in terms of donor selection and testing, what information did you have and from whom about what pharmaceutical companies were saying?
Well, I had it from representatives, and it was verbal. But they were questioned fairly intensively because the products had a bad reputation in the 70s, and they were conscious that they would be asked these questions and that they would have to give a convincing answer. I mean, I had to rely on the fact that they were telling me the truth. They were no more likely to have the truth in any documentation or literature they produced, and they did produce literature actually to go with their product, and again that told the same story. These were licensed products. It's very hard to interrogate what commercial companies are doing if they choose to tell you untruths, but ultimately I had to accept that these were ethical companies and that the information they provided was true. And that was my position.
Can I ask you to look at one passage in Dr. Main's statement? WITN 0736009, please, Sally. And if we could go to page 15. Yes, so it's the first 3 paragraphs I just wanted to read out and invite your observations on, Dr. Dempsey. This was Dr. Main talking about cryoprecipitate. She says, when planning for home treatment with concentrates, I was anxious and apprehensive about repeatedly injecting patients with any material, particularly over periods of weeks and months via the intravenous route. Therefore, I decided that all children should remain on treatment with cryoprecipitate. This was early in the 1970s, and Dr. John Bridges, the paediatric haematologist, was happy with the decision. Later in 1982, his newly appointed successor, Dr. Dempsey, was even more enthusiastic about using cryo in this way than myself. However, we agreed an exception should be made in respect of a very limited category of patient. 14.4, in addition to the 2 severely affected paediatric patients already on home treatment, it was decided that patients with brain injuries or those who required major surgery should have definitive amounts of factor VIII concentrate to guarantee the achievement of 100% factor VIII levels. Fortunately, the situation never arose and concentrates were never used in those circumstances during my time. Now, just want to, before we look at 14.5, I just want to ask you about a couple of matters there. Firstly, this indicates, it would appear, a decision in the 70s by Dr. Main that children should be treated with cryoprecipitate, and then suggests that you were an enthusiast for cryoprecipitate. That would appear to be incorrect based upon the evidence you've provided to the inquiry.
I think that would be putting it a little strongly to say that I was even more enthusiastic. I accepted what the treatment arrangements were when I came initially, and I proceeded to treat patients as they had been treated prior to my appointment. So that was my approach to cryoprecipitate at that time. I wouldn't say I was even more enthusiastic, but that would be my position, yeah.
When you decided to change the approach from cryoprecipitate for your moderately affected patients to commercial concentrates, did you discuss that with Dr. Main as far as you can recall?
Well, I think, oh yes, at some stage she would have been aware of what I had decided and what I did, but I made the decision and I took the action I did. And I didn't look to her for approval of the action I took. So it was my responsibility, my decision, and my action to change the treatment and do what I did. I definitely, she was definitely aware of it at some later stage because I remember talking to her about it. She didn't register any particular comment in relation to the information, as far as I can remember.
And then you'll see the reference in 14.4 to the 2 severely affected paediatric patients who were on home treatment. Now, that may be patients who've been established as paediatric patients in the 1970s. But did you have any awareness of Dr. Main having paediatric patients under her care?
No, I know that Dr. Bridges, Professor Bridges, had a close link with Dr. Main, and any decisions to put pediatric patients on concentrates in the 70s were arrived at jointly. There may have been one boy severely affected boy on concentrate at around the time I was appointed, or before the time I was appointed, and I think he was referred to the adult unit having reached the age of 14 before I was appointed, and he wasn't there when I came back to the unit in August 1980, having worked in the unit up to December 1979. He was there in September or December 1979. He wasn't there in 1980, and I think he'd been referred to the Royal in the interim. But there were no other children on concentrate that I can recall when I took up post in August 1980. And there certainly were none on home treatment, and I don't remember any on home treatment when I worked in the Children's Hospital as a senior registrar in 1979.
And then you'll see paragraph 14.5, Dr. Main continues, due to their diminutive size, children did not require large doses of cryoprecipitate to be effective. This reduced the likelihood of allergic reactions, which were common in adult patients who did require larger doses. There are a number of problems associated with using cryoprecipitate in large doses, and then I'm not going to go through what she says in relation to that. You'll see there Dr. Main's view about cryoprecipitate being suitable for children. Do you recall discussions about that? Was that something you disagreed with?
No, I agreed with it up to a point. Again, there's a volume problem with children and of any size. I mean, a 15-kilogram child aged 5, if you're dealing with a bleed, you're going to have a fair amount of cryoprecipitate to syringe in through a vein if you're going to get a level up to 30-40% and control the bleed. Cryoprecipitate was fairly bulky, and it was fairly viscous stuff to try to give intravenously. And obviously, you wanted to affect a venipuncture on one occasion when you're giving the injection and not have it fail halfway through and have to needle the child again. So we're back to the situation where the size of the injection or the volume of the injection is quite important. So cryoprecipitate was fairly bulky. And for older children, the amount would probably necessitate erecting a drip and putting an intravenous cannula in. And I never liked doing that because intravenous cannulas could lead to thrombosis of a vein. And the hemophilia patient is critically reliant on venous access over a lifetime. And their veins needed to be protected and looked after from an early age. And erecting an intravenous drip, putting in an intravenous cannula was to be avoided if possible. So that was a side effect or a disagreeable attribute of having to use cryoprecipitate in anything, in any child over maybe about 15 kilograms, age 5 plus. So it wasn't all that convenient to employ it in routine care.
Again, I want to pick up some issues relating to cryoprecipitate in a while, but just sticking with what product choices were made, first of all, you've referred to June 1983 and advice from UK HCDO. Can we look at HCDO 40270_004? Now, this is a letter from Professor Bloom and Dr. Ritzer, dated the 24th of June 1983, headed AIDS. It refers in the first paragraph to a meeting of reference centre directors in May to discuss the problem of AIDS in haemophilia, its implications and recommendations. And then the second paragraph says this: at the above-mentioned meeting on May the 13th, the following general recommendations were agreed. 1, for mildly affected patients with haemophilia A or von Willebrand's disease and minor lesions, treatments with DDAVP should be considered. Because of the increased risk of transmitting hepatitis by means of large pool concentrates in such patients, this is in any case the usual practice of many directors. 2, for treatment of children and mildly affected patients or patients unexposed to important concentrates, many directors already reserve supplies of NHS concentrates, cryoprecipitate or freeze-dried, and it would be circumspect to continue this policy. So was it this document that led to your change of approach on the treatment of your moderately affected patients, Dr. Dempsey?
Yes, that's right. It was, yes.
And so in relation to the moderate patients, you stopped using the commercial concentrates and started using the SNBTS concentrates, is that correct?
Yes, that's right, yeah.
Did you have any particular problems or difficulties with the SNBTS product?
Well, no. I mean, I felt that it was a question of having to change product. And when I started to use it, I didn't have any particular problems with it. It seemed perfectly acceptable. Probably the volume of reconstitution was larger, and it was probably more difficult to reconstitute. In other words, you had to agitate the vial for a longer period of time to get the get the product into solution, but those were acceptable in the circumstances that we were dealing with then. Yes, it was an acceptable substitute for the commercial product.
And once you switched to the SNBTS product in 1983, did you then have to, in 1983 through 1984, until heat-treated concentrates came along, which I'll come to later, did you have to use commercial concentrates at all, or was there an adequate supply of SNBTS product to enable you to treat all your moderately affected patients with it?
Oh, there was an adequate supply, but we've got to remember that I was using fairly limited quantities of material at that time, because the cohort of patients were as they were, mildly, moderately affected, and they came infrequently, and the amount of product that was used was limited. So there was sufficient for my needs, yes, certainly.
And did you ask Dr. Main or ask the blood bank to ensure that there was always a sufficient supply of SNBTS product put aside for your patients, in other words, a system of prioritisation, or did you not need to do that because you were using it in such low quantities?
I didn't really need to ask them to prioritise my requirement, no. They knew I'd switched over. I spoke to Mr. Carville in the blood bank, and he was aware of that.
Now, the approach you'd taken up until this point, June 1983, in relation to the moderately affected patients, did that apply to all your moderately affected patients? I know the numbers are not huge, but all of them, irrespective of age? And do you recall what the age range was?
I can't remember what the age range was. I mean, we dealt with all age ranges. I can't remember what the age range was. I mean, these changes were effected with parental consent, of course. I mean, nothing was ever done without talking to the parents and explaining what we were doing or what we hoped to do and why. So there were lengthy discussions with the parents at that time about what we suggested was the best way forward.
And I'll come on later to ask you about the information provided to parents, but just in relation to the specific question, is it the case then that from a date in 1981, all moderately affected children, whatever their age, would be treated with the commercial concentrates, and then from June with the SNBTS concentrates?
Well, that was the plan. I can't remember any new patients who I would categorise as moderate turned up and got initiated on concentrate. I can't remember any new patient appearing who would have fallen into that category, because new patients back then were very few and far between, for whatever reason. So the cohort that we had were started on commercial product, and then that cohort was moved to SNBTS factory.
Did you have, in this period, the first half of the 1980s, any patients with inhibitors?
I thought not, but on reflection, I think there may have been one boy with a low responding inhibitor that was easy enough to manage by increasing the quantity of factor VIII you gave on each occasion. So you could neutralize the inhibitor fairly effectively. So it wasn't in any way a major problem. Other than that, we had no inhibitor patients.
Was there any policy of what some others refer to as batch dedication? In other words, trying to keep a patient, whether receiving a commercial concentrate or an SNBTS product, as much as possible on the same batch rather than different types of product or different batches?
Well, we tried to keep the product the same if possible. Keeping batches was extremely difficult, and I don't think we were ever able to get that to work. So try to keep the same product going insofar as possible, but dedicated batches, no.
Can I turn then to the treatment of patients with mild haemophilia in the first half of the 1980s? Your statement suggests that patients with mild haemophilia were treated with cryoprecipitate or DDAVP. Do you recall whether you ever treated a mild haemophiliac in the first half of the 80s with a concentrate?
I can't think that I did. DDAVP was used in the first instance. And then if we felt it necessary, cryoprecipitate, DDAVP and cyclocapron, tranexamic acid, and then cryoprecipitate. No, I don't remember. I don't remember using a concentrate.
I don't think we see DDAVP itemised on the annual returns during this period. Are you confident it was used at the Royal Belfast Hospital from in 1980 onwards?
Yes, it was, because I prescribed it. Collecting data on DDAVP was never very comprehensive. The patients were written up for the DDAVP. It was treated as a pharmaceutical product, given as a drug and treated as a drug. And data capture was never as well done as it should have been. So the fact that it didn't appear on returns to any extent doesn't necessarily mean that it wasn't being used. That's my feeling about DDAVP.
During that period in, I think, 1979 or so, where you were a senior registrar at the Royal Victoria Hospital and working for some part of your time under Dr. Main in the Haemophilia Centre, was DDAVP in use there, do you recall?
Yes, I think it was. Yeah, I think I remember it being used occasionally, yeah.
Did you ever use a porcine product?
No, because that was really for patients with high responding inhibitors, and I never had. In the early 80s, certainly, and in the 80s, I didn't have patients with inhibitors. Later on, when I did have patients with inhibitors in the 90s, I never used porcine factor VIII. We never had to use it.
And do you recall using the BPL concentrator tool in the early 1980s?
That was the Elstree factor VIII. Yeah. Yes. It's difficult to recall. I don't think, because it doesn't fit into my treatment regime, I don't think I probably used it. I don't think I used it. By the time I'd gone to NHS concentrate, it was SNBTS that I was using. But I think, I remember using it, I think, in Ward 22 on occasion in 1979.
Now, want to move to ask you some questions about hepatitis and then AIDS knowledge. And then I want to come back to some of the issues relating to product choices once we've explored that. But first of all, in general terms, can you recall what you learnt in your general medical training and then in your specific haematology training about the risks of viral transmission from blood or blood products?
Well, I think way back when I was a medical SHO doing membership exams, I think I appreciated that jaundice could follow blood transfusion. I think that was a well-established fact. Thereafter, in the 70s, mid-70s, I mean, I was aware that hepatitis B had been a problem, was a problem, especially around transfusion of blood products. And that was a problem that remained ever present until effective screening procedures were introduced But there was still a cohort of patients who were not hepatitis A sufferers, who weren't hepatitis B sufferers, who had experienced jaundice following transfusion, and they were referred to as non-A, non-B hepatitis sufferers because there was no agent that had been identified to account for it, and yet it seemed highly likely that a viral agent might be responsible. So that was the initial impression I had around hepatitis in the 70s. As for the severity of non-A, non-B hepatitis, well, I suppose in relation to hemophilia, we knew that there were a small number of patients who had serious liver disease, and that might have been related to preceding infection. It might have been related to preceding jaundice. But for the most part, we thought that patients who had jaundice following blood products made a fairly full recovery. And those who did show minor abnormalities in transaminase levels, we didn't think would progress to any serious state of ill health.
The inquiry has heard evidence about a World in Action documentary broadcast at the end of 1975, which looked at donor practices in the States and the contamination with hepatitis of concentrates being used in the United States and in the United Kingdom. Do you recall whether you saw or heard about that documentary at the time? I think this was during your time as in haematology training.
Yes, haematology training in the City Hospital. I may have seen it. I can't remember if I saw it at the time. Certainly heard plenty about it later on, but I would doubt that perhaps I hadn't seen it at the time. It was very relevant, of course, to patients with haemophilia, but no patients with haemophilia were seen in the City Hospital at that time. So I may not have seen it.
The inquiry is also...
It would have had general relevance in terms of blood products. After all, every haematologist used blood transfusion and platelet transfusions, and anything that related to the transmission of infection from blood products would have been of interest. Whether I saw it, as I say, I can't remember at the time.
You were the senior registrar 78 to 79 under Dr. Main and Dr. Bridges. Can you recall any discussions with them or any training from them about risks of hepatitis and the implications of hepatitis for decision-making on treatment of haemophilia patients? Because this was your first experience, I think, of haemophilia in 78, 79.
That's right. Oh, gosh, it was, I think it'd be fair to say they were well aware of it as a feature and as a potential problem. Yeah, it was discussed. Yeah, there was an awareness. There was nothing novel about it when I came to be a consultant. There was an awareness of the condition. And as I say, there were patients, I think, who were known to the unit and with haemophilia who had severe liver disease. So it was very much a topic that was comprehended.
The inquiry has heard evidence about a paper published in 1978, work from Sheffield under Professor Preston involving liver biopsy analysis and looking at the consequences in terms of chronic liver disease in relation to haemophilia patients. Is that a piece of work or a publication that you recall being aware of at the time?
I can't say that I was aware of it being discussed. It may well have been discussed. I've heard of it since very many times. It's very hard to know when you first hear about a bit of information like that, or first hear of a paper, when you've heard about it at length subsequently. So it may have been discussed, and indeed it probably was, but I can't say for certain. I remember it being discussed in 1978.
So I note the time. I've got a number more questions on this topic, so perhaps we could take a break now and then pick them up afterwards.
Yes, very well. Well, we'll take a break until 11:45. Now, Dr. Dempsey, this is the first break in your evidence. Let me say what I say to all witnesses at this stage, if I haven't already said it, and that is, you're giving evidence. You must not talk to anyone about the evidence you have given or the evidence you think you may yet be asked to give, but you can talk about anything else you like. I look forward to seeing you. I look forward to seeing you back at 11:45.